Okay. So this is the most recent guideline of RCOG, that is the investigation and care of a small for gestational age fetus and a growth restricted fetus. So there are some changes to this guideline. First of all, they have changed the monitoring, the gestational age for the delivery, and some changes in the definition also. Okay, so first of all, before going into the details of this guideline, in between I will be sharing some of the concepts as well. Okay, so the definitions that are important, first you should know about what is appropriate for gestational age. Later on I will also tell you how you will tell your examiner and how you will clinically apply this knowledge. Okay, so appropriate for gestational age is the fetal size between the 10th and the 90th centile. It is between the 10th and the 90th centile. Usually in some good hospitals, and there is a chart which we call grow chart, and it is used to plot these centiles for each and every patient. So on the one axis, there is the symphysiofundal height, and on the lower axis, there is the gestational age. Actually, I don't know how to draw in this, otherwise I would have drawn for you. But usually it's an axis like this, right? So here it is fundal height. On the lower axis, there is the gestational age. And on this side, there is the estimated fetal weight on ultrasound. If for some women, for a specific gestational age, if you do not have the ultrasound available, then they used to plot the using the symphysiofundal height. But if the ultrasound is available, then the estimated fetal weight of ultrasound is used to plot the chart. So there are two lines. One is at the 10th centile, one is at the 90th centile. If the fetal weight falls between 10th and 90th centile, we consider it as normal. Is it clear up till now? What is the appropriate for gestational age? This is clear? Please be active in the chat box. Okay. Now coming towards small for gestational age fetus. This type of fetus will just have the estimated fetal weight or the plotting of the symphysiofundal height below the 10th centile. There will be no changes to the Doppler. Okay? Only the estimated fetal weight would be less than 10th centile. Okay? Now, what is the difference between fetal growth restriction and small for gestational age fetus? Small for gestational age fetus is only the fetal size, means either the abdominal circumference or the estimated fetal weight is less than 10th centile. For FGR, the fetus has to be small if the fetus is less than third centile. Only the size is the abdominal circumference or the estimated fetal weight is less than third centile. This is the single criteria for the fetus to be the growth restricted fetus. Okay, but because we already know if the fetus is less than 10 centile, it is SGA. For a fetus to be less than 10 centile along with the Doppler abnormalities, then we call this fetus as a growth restricted fetus. Okay. So what are these Doppler abnormalities that we will study one by one? Now coming again, appropriate is between 10 to 90th centile. The small is just the fetal size, that is the abdominal circumference or the fetal weight less than 10 centile. The growth restriction is either one of the following. Even if the fetus is less than third centile, either through the abdominal circumference or size, this single point is sufficient to label a fetus as a growth restricted fetus, despite whether the Doppler is normal or abnormal. But if the weight is less than 10 centile, but there are Doppler abnormalities, then this fetus is not an SGA fetus, but this is actually a growth restricted fetus. Okay, clear up till now? Okay, now we will go towards further. Okay. Now here you see in this new guideline, a new term is introduced, which is called early IUGR and late onset IUGR. So the early IUGR is detected before 31 plus 6 weeks, and the late is 32 weeks onwards. Okay, so there are certain abnormalities or certain characteristics which can tell us about whether it is an early apart from the gestation. So जो मेन थिंग है जिसमें आपने याद रखना है उसमें आप फर्स्ट ऑफ ऑल यू हैव टू कंसिडर द gestation. If before 31 plus 6 weeks, it is early onset. If after 31 plus 6 means 32 weeks onward, it is late IUGR. So these are the three, because in this guideline, the definition of SGA is changed. If it's less than 10 centile, it is SGA. Less than 10 centile with Doppler abnormalities is restriction. Early onset is up to 31 plus 6 weeks. And after 32 weeks, it is the late onset. Okay. Now, the other term that is introduced in this guideline is the static growth. So, what is static growth? When there is no forward growth velocity in the estimated fetal weight or abdominal circumference measured at least 14 days apart, then we call it as a static growth. So you should learn these things by heart. First, the definitions, then the early onset gestations, and then the static growth. Okay. Now, one more thing I want you to learn, how you will do the risk assessment, that whether this pregnancy, this fetus was IUGR in the previous pregnancy or no, and what is the definition of FGR, not IUGR, the new term is the FGR in the current pregnancy. So these things are important because when you clinically apply this knowledge, first of all, the clinical application of the guide, this definition is very important. So if you get a question or you get a scenario in which the fetus is just below the 10 centile without Doppler abnormality, then you will manage this patient as SGA. So SGA fetus has different line of management compared to FGR. Okay. So now when you know that the estimated fetal weight or abdominal circumference is less than third centile, so now you have to plan the pregnancy and the management plan would be for FGR patient. Okay. So this is important to know about the, that's why I was waiting for rest of the cults to join, because in between it is causing interruption. Okay, now the previous pregnancy is important because you will be asking about the past history. So I am incorporating this guideline, that how you will apply it clinically. Okay, so the previous is, if the birth weight, now you see birth weight, if the birth weight was below third centile in previous pregnancy. Okay, so in our country, we do not use these growth centiles. But when you will be using somewhere, when you will be working somewhere else, so this growth chart is used. So for every baby, even if the baby is born, when you start plotting the growth chart for your patient, first they will ask about the BMI, the ethnicity, the height, weight of these patient for whom you are plotting the chart. And the next option would be about the previous babies also. So they will give you, and then when you click the calculate, there will be a chart created, and that chart will show that her previous babies were on this centile, and now you have to plot for the new pregnancy. So when you put the information in these charts, that is the growth chart or any other chart, then it give you the about the current pregnancy, tell you about the current pregnancy and as well as the previous one. So if on the growth chart you notice that any of the previous baby is less than third centile, it means that this pregnancy is high risk and because she had the previous FGR. Okay. Other thing would be so this means that you will tell your examiner, I will be asking about the previous birth weight of the baby. So not just the birth weight, because the birth weight is not going to tell you anything. You will ask that I want to know about the birth weight centile, whether it was below the third centile. Okay. Now, if the previous pregnancy has an early onset preeclampsia or FGR necessitating birth before 34 weeks, it means that this patient has the FGR in the previous pregnancy. And if the birth weight was below 10 centile with the evidence of placental dysfunction, it means that this was the previous FGR. Now, in the current pregnancy, we already discussed that either the estimated fetal weight or abdominal circumference below the third centile. So, if this one is present, then we call it as the FGR. But if it is below the 10th centile with Doppler abnormalities, now what are these Doppler abnormalities? Here it is elaborated. Abnormal uterine artery Doppler means the pulsatility index above 95th centile. So you should keep this thing in your mind that whether the umbilical artery Doppler, whether the uterine artery Doppler, with the advancing gestation, the pulsatility index will decrease. So what is the pulsatility index? Pulsatility index is resistance to the blood flow through the placenta. So with advancing gestation, it is the normal physiological mechanism that the blood flow to the placenta, the resistance is decreased because the fetus needs a large amount of blood. So whenever you see an above the 95th centile for both the umbilical and uterine artery Doppler means that the resistance is on the higher side. Usually, normally, the resistance should be on the lower side. So whenever you see that the pulsatility index, whether it is for the uterine artery Doppler or whether it is for the umbilical artery Doppler, and it is on the higher side, it means that there is some functional functional capacity of the placenta is reduced, and there is some resistance to the blood flow through the placenta, and it will result in FGR baby. Okay, clear up till now? Clear? Okay. So the concept for the pulsatility index above the 95th centile is now clear. So let me revise again. The previous FGR would be if the birth weight, not the estimated fetal weight, the previous birth weight of the baby below third centile, early onset preeclampsia or FGR necessitating birth before 34 weeks, or if the birth weight was below the 10th centile with the evidence of the placental dysfunction. Now, the current one is either the estimated fetal weight or abdominal circumference below third centile, estimated fetal weight or abdominal circumference below the 10th centile with the evidence of placental insufficiency in the form of abnormal uterine artery Doppler or abnormal umbilical artery Doppler. So these definitions and the previous and the current definition should be in your mind along with the gestation of the early onset and the late onset. Because further in the guideline, they have explained that On what basis you will say the patient has early early onset FGR, and on what basis you will say it is the late onset? Okay. So this is, now you see here, usually the early onset FGR is more common. The late onset is less dangerous. Okay. Early onset is mostly due to placental insufficiency and is easily detected. What is the, and with the early onset FGR, the most likely Doppler abnormality or most associated one is the uterine artery Doppler. For the late onset, what you would be following is the umbilical artery. Okay, clear? Okay. So the definition is clear, whether it is the early onset or the late onset. If it is less than third centile, for the early onset FGR, it is, we already know it is less than 32 weeks. That is 31 plus 6 weeks, right? 31 plus 6 weeks. Here, either if the umbilical artery Doppler is abnormal, that is absent end diastolic flow, or the estimated fetal weight or abdominal circumference is less than third centile. Okay, not just the less than third centile. Even if the umbilical artery Doppler is abnormal, less than 32 weeks, we say it is FGR. So you should think about these things. It's not just rectify these things. If you see a patient with umbilical artery Doppler, she's less than 32 weeks, and the umbilical artery Doppler shows that there is absent end diastolic flow, it means that it is FGR. If there is no Doppler abnormality, but it is less than third centile, we will say it is FGR. But in comparison, if you see to the late onset, even if there is no Doppler abnormality, but only the AC or estimated fetal weight is less than third centile, we mark or label the patient as late FGR. Okay? For early onset, the difference is that if the umbilical artery Doppler is abnormal, still we will label the patient as FGR. So, in this case, either the Doppler abnormality or the estimated fetal weight less than third centile makes the patient eligible to be labeled as FGR. If this one we already discussed, that if it is less than 10 centile combined with either the uterine artery Doppler or the umbilical artery Doppler more than 95th centile, it is FGR. But for the late onset, here, here we say that less than third centile or the umbilical artery Doppler is abnormal, we label the patient early onset. And here, with less than 10 centile, we combine it with the Doppler abnormality, and that Doppler abnormality could be uterine or could be umbilical. Okay? But for the late onset, two of these three things should be present. Why for the late onset? Because I already told you, the uterine artery Doppler you will only see up to 32 weeks. Okay? Uterine artery Doppler. After 32, that is the late onset FGR, there is no role of uterine artery Doppler. Because later in the pregnancy, the uterine artery Doppler becomes normal. And even if in the early pregnancy it is abnormal, later on it becomes normal, still there is a chance that patient has a risk of FGR. But for the late onset, there is no role of the uterine. They are using the umbilical artery Doppler. Because for the cerebroplacental ratio, we also require the umbilical artery Doppler because it is the ratio between the middle cerebral artery Doppler that I will explain in detail later on. But for the moment, you just remember this, that at least two of the three criteria should be present to label the patient after 32 weeks as a late onset FGR, because for late onset, if it is less than third centile, we are clear that it is FGR. No other criteria is required. But if it is less than 10 centile, then we need at least one more thing to label the patient. Either it should be cerebroplacental ratio less than fifth centile, or it should be umbilical artery Doppler. Now you see here one thing, or one is the abdominal circumference or estimated fetal weight crossing the centile more than 2 quartiles. This 2 quartile means that once you plotted the fetal weight or the fundal height according to that the gestation on the growth chart or any customized chart, then when you are plotting the next time, it is more than 50% drop in the centiles. Okay, but now you see here the cerebroplacental ratio if less than fifth centile. So if you try to memorize the things that less than fifth centile, more than 95th centile, then you will keep on forgetting. You need to make your concept. The one concept that I have given to you is at the start of the pregnancy, the uterine artery and umbilical artery both have high resistance. But with the passage of time, this resistance falls because we need the placenta to be a low resistance reservoir. Okay. So this 95th centile means that it is more. Fifth centile means less, 95th more. So if the umbilical artery Doppler or the uterine artery Doppler is showing more than 95th centile, it means that resistance is on the higher side. But for these two vessels, the resistance should be on the lower side. Am I clear up till now? If yes, then we will proceed forward. Okay. So here, for the late onset, you see here the cerebroplacental ratio is less than fifth centile. So what does this mean, the cerebroplacental ratio less than fifth centile? Does it mean it's on the higher side, or it means that it is on the lower side? It means it is on the lower side. Usually, the cerebroplacental ratio is the ratio that is between the middle cerebral artery Doppler pulsatility index and the umbilical artery Doppler pulsatility index. What does this mean? Usually, the umbilical artery Doppler pulsatility index and the middle cerebral artery Doppler pulsatility index, the ratio is called cerebroplacental ratio. This cerebroplacental ratio is equal, means at the middle cerebral artery and umbilical artery, it is 1:1. It means that both to the brain and rest of the body, the blood supply is equal. Okay. But whenever you see it is a ratio of middle cerebral artery to the umbilical artery pulsatility index. So the middle cerebral artery, if the blood flow or the pulsatility index is high, it means that the cerebroplacental ratio would be high. Okay. But in the umbilical artery Doppler, because they are in inverse relationship, right? They are in inverse relationship. The cerebroplacental ratio, if less than fifth centile, it means that the resistance is on the lower side in the middle cerebral artery Doppler. If the resistance is on the lower side, it means that the blood flow towards the brain is more as compared to rest of the fetus. Usually, let me explain again to you. Usually this ratio is 1. Okay, 1:1. But when there is a brain sparing effect, mean there is an FGR fetus, it means that the blood supply to the brain is more. So there some changes occur in the cerebral blood flow circulation, that the middle cerebral artery pulsatility index reduces. So when it reduces, it means that the resistance is reduced and there is more blood flow to the brain as compared to rest of the body. Is it clear? So this cerebroplacental ratio less than fifth centile means, and here you see the umbilical artery is more than 95th centile. It means, and this ratio should be same. Okay. The umbilical artery and cerebroplacental, the blood flow should be same to both. But whenever there is an FGR fetus, the ratio, this less than fifth centile means the resistance in the cerebral circulation is reduced and blood flow to the brain of the fetus is more as compared to rest of the body. So it shows that it is an FGR fetus. Clear? Clear? Okay. Now let me recap these things again, because once you learn these things, the whole guideline is very easy. First thing we discuss about appropriate for gestational age, which is 10 to 90th centile. The third one is SGA, which means that it is less than 10 centile without any Doppler abnormality. The fourth thing we learn about FGR is either less than third centile, or if it is less than 10 centile, there is some Doppler abnormality. But that Doppler abnormality is different for the early onset and the late onset. For the early onset, either the umbilical artery Doppler if absent and diastolic flow, or it is less than third centile, the estimated fetal weight, it is the early onset FGR. But if it is less than 10 centile, either with the uterine or the umbilical more than 95th centile, this more than 95th centile means more resistance to the blood flow through the placenta, and the higher the risk of the FGR fetus. Now see here, the late onset one is clear cut, that if less than third centile, there is we can label this patient as FGR if it is more than or equal to 32 weeks. But if it is less than 10 centile, there should be some accompanying feature. That accompanying feature, we already know that should be some Doppler abnormality. But that Doppler abnormality is not the uterine artery Doppler, it is the cerebroplacental ratio and the umbilical artery Doppler abnormalities. Along with, even if the estimated fetal weight is not less than 10 centile, but you are plotting it on the growth chart and it is crossing the 2 centiles or 2 quartiles, that is 50% decrease in the growth, along with these things, the abnormal Doppler, still we will label this patient as FGR. Okay, clear up till now? Okay, so now the small fetus. The small fetus could be normal, constitutionally small, non-placental mediated growth restriction. Non-placenta mediated is which type of growth restriction? It is due to the chromosomal abnormalities, due to certain infections like CMV, like toxoplasmosis, malaria, Zika, and some inborn errors of metabolism. And then the placenta mediated growth restriction that we call FGR. Okay. So this is the basic concept. If you have this concept, only you can manage the patient, because you should know which patient I should label small, which patient is the FGR, or which patient is the previous FGR, history of previous, and what is the diagnostic criteria for the current. Now, all women should have a risk assessment for FGR carried out by 14 weeks. Now, this risk assessment is actually your history that you should take from your patient, that I will tell you in a while. So this risk assessment should always consider the previous medical history. So your history template for FGR should include the previous medical, but not randomly asking the previous medical, some important factors that I will later on tell you. And then the obstetrical history and current pregnancy history. So this current pregnancy history is also very important. This current pregnancy history usually in UK and any other country, they usually offer the screening, that is the Down syndrome screening to their patient. To each and every patient they offer. It depends upon the patient whether they accept it or no. But you have to offer to each and every patient. Okay. And now this current pregnancy history, they have incorporated some new terms in the guideline. With that I will discuss in a while. So how you will use this, the monitoring or the antenatal risk assessment for Down syndrome, how those parameters you will
All
utilize
pregnant women should
to
have
know
a
about the
specific fetal growth restriction carried out by 14 weeks of this.
whose mic is on mute. Okay. So the how you will incorporate in your history taking or the management of the patient, because this is very important. This is new point. So women must also be assessed at booking for the condition where symphysiofundal height measurements are not appropriate. So this is your other history point. You have to ask about BMI of the patient, because this is very important. In these patients, you cannot plot the symphysiofundal height, but you have to do the ultrasound to know about the estimated fetal weight to plot the chart.
The woman
Okay.
should be assessed at the booking for the condition of the cervical fundal aorta.
Whose mic is unmute? Girls,
BMI
kindly
of
mute
30
yourself.
or above at booking with the presence of fibro.
Whose mic is unmute? Okay. Clear up till now? Okay, so this is not just the history of BMI, but you have also to ask about the fibroids in the uterus. Okay, so this is also a part of your history. The other history is you will not ask about the mode of delivery. Previous obstetrical history in relation to FGR is important. You should ask about the birth weight, the gestation, or birth weight centiles. Why gestation is important? Because previously we have learned that in the previous pregnancy, if some pregnancy or placental mediated problems resulted in the delivery before 34 weeks. Okay. This chart is very important. All of this chart is important because all these points you will be asking in your history. Okay. Once you have taken your history, the history points like age, BMI, past medical history, past surgical history, obstetrical history, the personal history of the BMI, also the what we call it, the personal history of age. I wanted to emphasize on the age because age is also a risk factor for the FGR. Okay, so now these are your history points. You will, the targeted focus history means that whatever is relevant to your case, you should ask that. The first one is the no risk factors. And the one other point they have introduced in this guideline is that at anomaly scan, you should utilize this visit of the patient, and every patient on anomaly scan, you should do the estimated fetal weight of that patient. If the estimated fetal weight is more than or equal to 10 centile and there are no risk factors present, it means that this is a low risk patient and you should do only symphysiofundal height measurement for these patients. Okay. So symphysiofundal height measurements start from 24 weeks, but at 28 weeks, you should have plotted one of the symphysiofundal height at least. Okay. Clear up till now? How you will manage the low risk patient? Dr. Shumaila is asking, कैसे पता चलेगा कि fetal weight is less than 10 centile or more than 10 centile? Dr. Shumaila, unfortunately,
Yes, ma'am.
we are not using the growth charts in our country. We are not plotting any symphysiofundal height. We are just roughly measuring the symphysiofundal height, and then we check whether um, if the discrepancy is of 4 weeks, then we start labeling the patient as FGR, and then this is what is our current practice. But this is not according to the standards. Okay, the standard practice is that whenever you see a patient, because in some country like in UK, they are plotting after 24 weeks the symphysiofundal height on a chart. So this is a kind of chart with gestational age given at the bottom on the x-axis And on the y-axis, on one side, that is the left side, there is symphysiofundal height measurement given. And on the right side of the left axis, like if you draw it, on the x-axis, there is the gestational age. On the y-axis, either you can plot through the symphysiofundal height or you can plot through the estimated fetal weight. If the patient is coming to you and she has already done her growth scan and you have the estimated fetal weight, then let's suppose your patient is at 28 weeks, then you will mark 1 point on 28 weeks and then you will check whether her symphysiofundal height is 28 weeks or not. Then you will join these lines and it will clearly tell you whether it falls between to 10 and 90th centile, or it is below the 90th centile or above the 90th centile. Is it clear? Is it clear? Okay. So this is how you will plot. Now the patient is low risk, right? The patient is low risk. She is having no risk factor. And you on anomaly scan also her estimated fetal weight. And one more thing I want to tell you. If the patient has not done the growth scan or you have no ultrasound, then you will use the symphysiofundal height to plot the chart. But if you have the estimated fetal weight, then you can use the estimated fetal weight given in the ultrasound. But for both of them, whether you are plotting with symphysiofundal height or you are using estimated fetal weight, there are two clear lines. One is the 10th centile, one is the 90th centile. Then one is the 10th, one is 90th, and it shows you whether it falls in between or below or above it. Okay. Now for this patient, you will just monitor for serial symphysiofundal height, because already we have checked the anomaly scan. It is more than or equal to 10 centile. Means this is not less than 10 centile. You know, I already told you if less than 10 centile, it is SGA. So if you have a low risk patient, an anomaly scan is done, and estimated fetal weight comes out to be less than 10 centile, then your patient automatically falls into this high risk group. Now for this patient, you have to uterine artery Doppler as well. Clear? But if it is more than 10 centile or equal to 10 centile, then and no risk factor, then you just plot her serial symphysiofundal height measurement starting from 24 weeks, but you should have done at least one at 28 weeks. Okay.
मैम ये बात दोबारा बताएं प्लीज.
Okay. So if one patient, let's suppose patient X is coming to your clinic, you have taken the history, which I will tell you what you will ask from the patient later on. But if you have taken the history and there are no risk factors present, right? And now this patient, because every patient is going to have an anomaly scan at 18 to 22 weeks, isn't it? So when now they say that every patient, if she's here for an anomaly scan, then you should utilize this visit and check her estimated fetal weight also. If the estimated fetal weight is more than or equal to 10 centile, then this patient is low risk and you will just do the serial symphysiofundal height measurements. Clear? But now, if this patient, the estimated fetal weight comes below the 10 centile, it means that this patient is no longer a low risk patient and she is a high risk patient, because estimated fetal weight less than 10 centile in current pregnancy is a high risk factor. Wait, let me show you. Here you see, this patient estimated fetal weight less than 10 centile is a high risk factor, and this patient you will subject to uterine artery Doppler. Is it clear now? Pathway for the low risk patient will change suddenly if her estimated fetal weight is less than 10 centile. Clear now? Okay. If less than 10 centile, that I will just tell you in a while. Wait. Now, what are the points you should be emphasizing in your history? One is the moderate risk factor, but you cannot take history from a patient like this, that ma'am, I want to know about the moderate risk factor, I want to know about the high risk factor. No, you should utilize these things and you should create a checklist with yourselves in a beautiful manner, starting from the age, BMI, then you incorporate in the personal history about the smoker, the drug misuse, the BMI of the patient, any eating disorder, any weight loss. Now, the past obstetrical, you would be asking about previous SGA, previous stillbirth, previous second trimester miscarriages, and then about the past medical history. You would be asking about the medical condition like chronic kidney disease, hypertension, SLE, complex cardiac diseases you would be asking about. The complex cardiac diseases are most likely to be the stenotic lesions if the patient is using anticoagulants. So this anticoagulant will fall into the drug history and you will ask about the drug history. The obstetrical history combine these moderate and the high risk factors both. Okay, moderate and high risk factor combine both. Whether you will be asking about hypertensive disease in previous pregnancy, previous SGA stillbirth. Now, I'm just telling you for the purpose of the history taking. Okay, so how you will do the history taking? In the current pregnancy, you will ask, I want to know about the antenatal screening for the Down syndrome, if any is done on this patient. So for that, you will be asking about the PAP, pregnancy-associated plasma protein A, inhibin. If there is any ecogenic bowel, they can give you the scenario like this as well, that on anomaly scan, there is an ecogenic bowel, how you will proceed forward. So you should keep in your mind about the ecogenic bowel, that if they are asking about this thing, you will subject this patient to the uterine artery Doppler and then manage accordingly. Current pregnancy estimated fetal weight less than 10 centile and single umbilical artery Doppler. So you know, now you know how you will take the history for SGA or FGR pregnancy. And if she's what, and you should memorize all these moderate and high risk factors on your fingertips, because the management will completely change with these risk factors. So once you are asking your patient, you should just not randomly ask them. If they are saying that she's a smoker only, and there is previous SGA, so she falls into the moderate risk factor. Along with on anomaly scan, if the estimated fetal weight is more than or equal to 10 centile, this patient you will start the serial scans from 32 weeks. But if she's smoker and previous there is no SGA but FGR, then you will do the uterine artery Doppler for this patient. Are you getting my point, what I want to teach? Okay, clear up till now? Okay, let me explain again. This one is clear, right? If a patient with no risk factors and on anomaly scan, the estimated fetal weight is more than or equal to 10 centile, then this patient you subject to serial symphysiofundal height measurement starting from 24 weeks and doing every 2 weeks. Okay, you should know this as well. You will be doing it every 2 weeks, right? Now, if a patient has previous SGA, but this was just SGA, means it was just, the baby was just less than 10 centile. There were no Doppler abnormalities, but there was a previous stillbirth. Then you ask whether the stillbirth, the baby was appropriate for gestational age. Means it was a stillbirth, but it was not an SGA stillbirth. It was, the baby was of normal weight, but it was a stillbirth, right? If smoker, if any current smoker, any, if she's smoking 1 cigarette, 2 cigarette or 10 cigarette or drug misuse. So how you will ask? Now I want to ask about, और यू विल से, अगर उर्दू में बताना है तो माजरत के साथ पूछना चाहती हूँ, लेकिन जरूरी है, तंबाकू नोशी का इस्तेमाल तो नहीं करती, ठीक है? और इफ इट इज अ केस बेस्ड डिस्कशन एंड यू आर टॉकिंग टू योर एग्जामिनर इन इंग्लिश, देन यू विल आस्क, आई वांट टू नो अबाउट द करंट स्मोक, her history of smoking is also not the past smoker, okay, the current smoker, is she currently smoking? The drug misuse. And age you will start ask from the start. Age more than or equal to 40 years at the booking, or BMI less than 18. Now the personal history, not about just the smoking or drug misuse, you will ask about the eating disorder also. Okay, or any reduction in her weight or bowel disorder. Now the past surgical history, you should ask about any surgery like gastric bypass. And in these two, the gastric bending is less dangerous, or you can say less leading towards the FGR as compared to the sleeve gastrectomy. Okay, it is a malabsorptive surgery. Only just gastric bending is not that dangerous. Now the previous history, obstetrical history of preterm birth or second trimester miscarriage, and this second trimester miscarriage was placenta mediated. If in the history, what were the diagnostic points for the previous FGR? It was the less than third centile, placenta mediated, birth less than 34 weeks. Any of these risk factors, if present, especially the placental dysfunction, then you will start giving this patient aspirin from 16 weeks. Okay, and this patient, if the moderate risk factors are there, because the anomaly scan we are doing for every patient, so don't try to memorize things, try to make your concept. Now this is the patient with moderate risk factors, she will be subject to the anomaly scan. Every patient we will be doing anomaly scan. So now they say at anomaly scan, every patient you would be checking for the estimated fetal weight. If the estimated fetal weight is okay, in this patient, she was low risk. The estimated fetal weight was okay, but we were just doing the symphysiofrontal height because she was low risk. Now she has the moderate risk factor. Although the anomaly scan and the estimated fetal weight is normal, but because the patient has moderate risk factor, so we will start the symphysiofrontal height measurements from 32 weeks, then every 4 weeks until delivery. Clear? Clear? This is clear? Okay. So next is the high risk patient. But you should be thinking about this thing as well. If the patient is low risk, but on the anomaly scan, if the estimated fetal weight is less than 10 centile, it means she falls into the high risk category. Okay. Now here you see the medical conditions. These medical conditions make the patient high risk for FGR. The autoimmune disease is complex cardiac disease. So you should be taking the targeted history for these. Instead of asking, do you have hypertension, diabetes? No, you will be saying that I want to know whether you have any chronic kidney disease, hypertension, SLE, or antiphospholipid or complex cardiac disease if you are talking to your examiner. Otherwise, you can ask about दिल की कोई बीमारी तो नहीं है आपको, गुर्दों की कोई बीमारी तो नहीं है, ब्लड प्रेशर तो नहीं है, ठीक है, चमड़े की कोई बीमारी जिसमें गुर्दे भी मुलविस हो, या आपके बार बार बच्चे तो जाया नहीं होते. फ्रॉम दीज पॉइंट्स यू कैन आस्क अबाउट द मेडिकल हिस्ट्री. नाउ कमिंग टुवर्ड्स द obstetrical history. Previous SGA was the moderate risk factor, but previous FGR is the high risk factor. Hypertensive disease in the previous pregnancy is a high risk factor. Previous SGA stillbirth is a high risk factor. Previous stillbirth appropriate for gestational age is a moderate risk factor, but previous SGA with a stillbirth is a high risk factor. Now these are the current pregnancy things. If she had a significant bleeding, echogenic bowel, estimated fetal weight less than 10 centile, because every anomaly scan we are checking this estimated fetal weight. If it falls below 10 centile, we will do uterine artery Doppler for this patient. Clear? Clear up till now? This pregnancy associated plasma protein A, inhibin, alpha fetoprotein, all these you are doing for your patients when you want to screen for the Down syndrome. Okay, clear. So now you have to open your mind for this portion. Okay, the other thing, if they can give this scenario as well, that the woman is having BMI more than 35, what you will do for this patient? You will be asking about the congenital uterine anomalies also, because even if their estimated fetal weight is okay, So you have to start the serial ultrasound from 28 week if the woman has a congenital uterine anomaly, and from 32 weeks if she is unsuitable, like having fibroids, polyhydramnion, or any other thing, until 4 weeks until delivery. So for moderate risk factor, also from 32 weeks. For fibroid, also from 32 weeks, every 4 weeks till delivery. Just for the uterine artery abnormality, specifically the septate and the bicorporeal uterus, you will start doing the anomalies, anomaly not, growth scans from 28 weeks. Okay. And if these risk factors are present, you should start 150 milligram of aspirin at night around 13 weeks, and I think up to 34 weeks you have to give. Now it will come and we will confirm it then. Then uterine artery Doppler. Now they have incorporated this uterine artery Doppler for every high risk patient. These are the high risk condition. If any of these condition is present, you will ask this patient to do a uterine artery Doppler. Now when the uterine artery Doppler is normal and the estimated fetal weight is, here you see, we don't do uterine artery Doppler for moderate. Here also the anomaly scan is normal and estimated fetal weight is okay. But it is a moderate risk factor, so we starting from 32 weeks. But here she has a high risk factors. So we do uterine artery Doppler. Uterine artery Doppler is normal and weight is normal. Here we are starting from 32 weeks, but we are doing every 2 to 4 weeks. The difference here is just 4 weeks, here 2 to 4 weeks. Now the high risk patient, the uterine artery Doppler is normal, but the estimated fetal weight is less than 10 centile. So we are worried about this patient and we start monitoring from 26 weeks. If either of the uterine artery Doppler or estimated fetal weight is abnormal, we start monitoring. Okay. If one of either of these, like either the uterine artery or estimated fetal weight, either the uterine artery or estimated fetal weight. Here you see this is normal, but one is abnormal. Here this is abnormal, but this is normal. But we are doing the serial measurement from 26 to 28 or 28 weeks, 2 to 4 weekly. Okay, give me 1 second, please. Okay. But whenever both the parameters are abnormal, either the abnormal uterine artery Doppler and you see here it is written and, okay. So both the parameters should be abnormal to refer this patient to the feto-maternal medicine unit. Is it clear? Now this patient is confirmed FGR. Okay. When the abnormal, because in the guideline, in the start definition is given that the estimated fetal weight less than 10 centile along with the Doppler abnormality, and that Doppler abnormality could be the uterine artery Doppler or it could be the umbilical artery Doppler. But usually the pathway starts with the uterine artery Doppler because we are doing this uterine artery Doppler from 18 to 23 or 24 weeks. So whenever both of these things are abnormal, now we have to refer this patient to the feto-maternal medicine. Okay, clear up till now? Clear? Okay. So now, these are few points I have written just for the purpose of the clinicals. Maternal age, if it is an IVF pregnancy, if the ethnicity is Southeast Asian, African or Black African, complex cardiac heart diseases, and these complex cardiac heart diseases are New York Heart Association 3-4, stenotic heart disease, and anticoagulant use. So medication, you can add beta blocker and anticoagulants together, gastric bypass and gastric bands, septate and bicorporeal uterine, and there is dose-dependent relationship with maternal alcohol consumption and SG, and also the smoking. Maternal caffeine, all these are your history points, okay? Bleeding in the first trimester, and then the malaria and Zika and CMV anemia, all these points how you can ask about. You can ask about CMV, any fever in the first trimester, fever, malaise. Zika has also the same feature, malaria, fever, and all the history related to malaria. And anemia, you already know, you will. Then there is risk reduction. This I'm now, I think I should go to this point first, and then we will discuss rest of the things. This one. Now you know that the patient, the previous chart, let me go back there. So we start from that portion, okay? This patient, let's suppose I give you the scenario. This is a patient, 40-year-old lady with chronic kidney disease, and she has previous FGR. Now you took this history, and on history you find her to be high risk. Now you ask her to do the uterine anomaly scan and uterine artery Doppler, because both could be done together also. Both we are doing around 20 weeks. So once the anomaly scan was done, uterine artery Doppler was done, and on anomaly scan you determine the estimated fetal weight. Both the uterine artery Doppler and the estimated fetal weight was less than 10 centile. Both were abnormal. Now you have referred this patient. So she must be somewhere 24 weeks or 22 weeks or somewhere, okay? Because this one we are doing around 22 weeks, okay? Or 20 weeks, because we can start from 18 weeks. Now, so this patient you have referred to the fetal-maternal medicine unit. So this patient is less than 32 weeks. It means that she has an early onset IUGR diagnosed. Clear up till now? When both the things are abnormal. Okay, for early onset, both the uterine artery Doppler and the estimated fetal weight was less than 10 centile. So this means that the FGR is diagnosed, because the diagnostic criteria is if less than 10 centile along with the Doppler abnormality. But at this moment, she is less than 32 weeks. So it means that she has an early onset FGR diagnosed, because we already studied that early onset FGR is less than 32 weeks. Now let me clear you one thing to you. If it is just less than 10 centile, it means that the patient is diagnosed with SGA. So why I want to emphasize here, whenever you have an SGA fetus diagnosed, you will be doing the biometry and the umbilical artery Doppler every 2 weeks, both the things every 2 weeks, okay? But for FGR, biometry, that is the estimated fetal weight, you would be doing 2 weekly, but the umbilical artery Doppler you will be doing weekly. This is the difference in this guideline for FGR and SGA. For SGA, you are doing estimated fetal weight and the Doppler every 2 weeks. But for these patients, the Doppler is weekly. Now, this is very important. You should be listening with both of your ears. Now, this is 24 to 25 plus 6 weeks, right? This patient, uterine artery Doppler is abnormal. This patient, estimated fetal weight is less than 10 centile. Now you are doing this estimated fetal weight and Doppler weekly. Let's suppose this patient now comes, but here, when you were doing the umbilical artery Doppler, the umbilical artery Doppler, absent end diastolic or reverse end diastolic flow was there. Okay. If you were monitoring this patient, at any point, if the umbilical artery Doppler shows the absent or reverse end diastolic flow, for these patients here is the individualized care, because the gestational age is not very good. So you will decide whether you want to deliver this patient or you don't want to deliver this patient. Okay. Now this point is very important. Listen carefully. Whenever umbilical artery Doppler, whenever the umbilical artery Doppler shows any abnormality, you start doing the monitoring 2 to 3 times per week instead of weekly. In this 2 to 3 times per week, you will be doing the umbilical artery Doppler along with the computerized CTG and ductus venosus Doppler. Clear? Whenever, let me come again to this point, that you had a patient diagnosed FGR because less than 10 centile with estimated fetal weight and the uterine artery Doppler was abnormal. Now you started the monitoring for this patient. Okay. This patient monitoring, you are doing 2 weekly estimated fetal weight and Doppler. 2 weekly estimated fetal weight and Doppler. Anytime or any point, if the umbilical artery Doppler shows any abnormality, so you will not be following this. Then you will be following monitoring of the umbilical artery Doppler 2 to 3 times per week. This is written inside the guideline that you will be doing the umbilical artery Doppler 2 to 3 times per week along with the computerized CTG and ductus venosus Doppler. Okay. Okay. Now this patient, you are monitoring, and there is just absent end diastolic flow or reduced end diastolic flow. Let me tell you first, reduced is more dangerous as compared to, absent is more dangerous as compared to reduced. So let's suppose you started monitoring for this patient, and this patient you were doing fortnightly scan and weekly Doppler. Okay. This patient from 24 came to 28 weeks, right? You were following this patient, let's suppose diagnosed with FGR at 24 weeks. But now she's 28 weeks, okay? Now she's 28 weeks and her umbilical artery Doppler shows that there is absent end diastolic flow. Absent end diastolic flow, okay? Now absent end diastolic flow is shown. You will increase the monitoring to 2 to 3 times umbilical artery Doppler along with computerized CTG and ductus venosus Doppler. Now this ductus venosus Doppler is normal, computerized CTG is normal. But on the umbilical artery Doppler, there was a reduced end diastolic flow. Okay, there was reduced or absent, whichever it is. Now you see the patient is 28 plus 6 weeks. 28 plus 6 weeks. And her ductus venosus is normal. Her computerized CTG is normal. But the umbilical artery is showing reduced end diastolic flow. Still, you will monitor these patients with 2 to 3 times per week umbilical artery Doppler, computerized CTG, and ductus venosus Doppler. And once this patient reaches 32 weeks, you will deliver this patient, or you can consider from 30 weeks. Is this clear? Or if it's not clear, I'm repeating again because this is very important. Clear? Yes, it is absent and reverse both. Let me explain again. The same patient that you started to monitor with the uterine artery Doppler and estimated fetal weight, she is now diagnosed FGR. Now for FGR, what is your monitoring according to a guideline? Twice weekly Doppler, and after every 2 weeks, you have to do estimated fetal weight, right? Now you are doing the weekly Doppler, and the Doppler show, I will first go with the reduced. Reduced or reverse? Sorry, reverse. Okay, reverse, not reduced. Okay, so reverse, right? Or I will first go with the absent because absent is not that dangerous, right? As compared to the reverse. So if absent, right? If absent, you will increase your monitoring. You will increase your monitoring. But your target is that if umbilical artery Doppler is showing absent end diastolic flow, still you can deliver this patient by 34 weeks and consider from 32 weeks. Okay. But let's suppose if this patient at 28 weeks, at any point in time, the ductus venosus Doppler is showing the absent A wave, or the computerized CTG is showing the short-term variation less than 2 milliseconds, then you will not wait for this patient up to 32 or 34 weeks because the Doppler was showing absent. You will deliver the patient there and then. Is it clear? Is this point clear now? Let's suppose your patient is 28, let's suppose your patient is 29 weeks, right? 29 weeks and her Doppler, umbilical artery Doppler is showing reverse end diastolic flow. Then you can consider delivery after 1 week because guidelines say you can deliver after 30 weeks. Here you see, it says that you can consider from 30. But if she's diagnosed at 29 and this one is showing the reverse end diastolic flow, but this computerized CTG and ductus venosus Doppler is normal, still you can take this patient to 32 weeks. But anytime during this monitoring, this one we already know that it is absent and reverse. But we are following this. Whenever the computerized CTG or ductus venosus Doppler becomes abnormal, you will not wait for the specific gestation. You will deliver your patient there and then, whatever gestation it is. Clear? They will not ask about the short-term variation normal value. Okay, they will not ask about the normal value. You should just know about these things, because the examiner can just ask you about if the short-term variation is this much, how you will do. If it is this much, what you will do when. And then they can ask about the main things, like if it is absent, if it is reverse, when you will deliver. Okay, now here, this, what does this box mean? This box mean that you can plan your delivery upon the ductus venosus Doppler up to 33 plus 6 weeks. Up to 33 plus 6 weeks. After that, you will not be using ductus venosus Doppler. Here, if it is late onset FGR, means after 32 weeks, either, although it is a late onset, but still up to 33 plus 6, you are using ductus venosus Doppler. Okay. And anytime if there is an abnormality. Now this, the short-term variation is different for different gestations, right? 26 to 28, it means that it should be more than 2.6 millisecond. But if at 26 to 28, it is less than 2 millisecond, then you will deliver your patient. At 31 plus 6, if it is less than 3.0, then you will deliver. At 33 plus 6, if it is less than 3.5, then you will deliver. Now, how you will memorize these things? See, here it is 33 plus 6. 33 plus 6, so 3.5. Up to 31, the only value is 3, so up to 3. 28, 26 to 28, so 2.6. Whenever the A wave is absent or the short-term variation, you will is less than the specific gestation, you will deliver your patient. Otherwise, if this patient you started monitoring and just her uterine artery Doppler was abnormal and estimated fetal weight was less, but up to 33 plus 6 weeks, her umbilical artery Doppler was just showing absent end diastolic flow, you can deliver this patient by 34 weeks. Is it clear up till now? How you will manage and how you will? I hope it is making sense. Okay. Okay, good. So after 32 weeks, we know that it is late onset, but your ductus venosus Doppler will determine the mode of, not the mode of delivery, the time of delivery up to 33 plus 6 weeks. Okay. Now from 34 to 36 plus 6 weeks, for these patients, now you are doing this umbilical artery Doppler. Okay. And the middle cerebral artery Doppler, this will just determine about the frequency of the umbilical artery Doppler, but before 37 weeks, you cannot use the middle cerebral artery or cerebroplacental ratio to determine the delivery. Here, how you will determine your delivery, that whether you're going to deliver the patient or not. Now let's suppose the same patient, okay? Here I have delivered these patients, but now let's suppose the same patient we started monitoring here at 24 weeks, but she's doing well up to 33 plus 6 weeks, and now she's 34 weeks. Now you are doing the umbilical artery Doppler. Here your delivery will depend upon the pulsatility index. The pulsatility index at the advanced gestation should be less, but here it is more than 95th centile. Now, when the pulsatility index is more than 95th centile, now you will monitor with twice weekly computerized CTG. Here you were using the umbilical artery Doppler earlier. After 34 weeks, you are using the umbilical artery Doppler, but the pulsatility index. And here the short-term variation, because the computerized CTG. You see here ductus venosus Doppler was there, but here there is no ductus venosus Doppler. At 34 to 36 weeks, the baby is mature enough, right? Now, if the umbilical artery Doppler is more than 95th centile, or the computerized CTG shows the short-term variation less than 4.5, or the umbilical artery show absent end diastolic flow. Here you see we were delivering the patient at 34 weeks if the ductus venosus and everything was normal, because the preterm birth is more dangerous as compared to then FGR baby. But here already the baby has grown to 36 plus 6 weeks, up to 36. Now when the umbilical artery Doppler is absent after 34 weeks, you will consider delivery of the patient there and then. Means when you are monitoring weekly Doppler, and now the umbilical artery pulsatility index is more than 95th centile, you will increase the monitoring to twice weekly CTG. But if the umbilical artery Doppler shows absent end diastolic flow, you will straight away deliver your patient. Okay? But if the umbilical artery is not showing any absent end diastolic flow, only the pulsatility index is raised, then you deliver the delivery between 36 to 36 plus 6 weeks. Is it clear? Is it clear? Clear for all of you? Okay. Now the new thing in the guideline is, and now let's suppose if you are monitoring your patient and she's an SGA, right? So for SGA, the monitoring frequency was 2 weekly, both for estimated fetal weight and the umbilical artery Doppler. And everything is normal for your patient. Nowadays, previous guideline was saying you deliver SG at 37 weeks. Now they say that if everything is normal, you can take up this pregnancy up to 39 plus 6 weeks. Okay, this is I'm talking about SGA. For FGR, they say that you should plan the delivery at 37 weeks and you should have delivered the patient at 38 plus 6 weeks. Okay. Now it is the term 37 weeks onward. Same you will be doing fortnightly umbilical artery, weekly umbilical artery Doppler and estimated fetal weight fortnightly. Now if your pregnancy has reached so far up to 37 to 38 plus 6 weeks, you have to straight away deliver the patient by 37 plus 6 weeks if the AC or estimated fetal weight is less than third centile. Okay. If this is the reason, you straight away deliver your patient. No FGR patient should go further than 37 plus 6 weeks. For FGR, the cutoff is 37 plus 6 weeks. For SGA, the cutoff is 39 plus 6 weeks. Okay? Is it clear? The management part is clear. Now you can do induction of labor for an SGA patient. You can do induction because the examiner will be asking you whether you will go for induction or you will go for the cesarean section. So I will be teaching that as well. For which patient you would be doing the cesarean and for which patient you will be doing the induction. Okay. Now clear? Okay. So these are some points I wanted to tell you, but main of the guideline is already done. Few more points I wanted to emphasize on. This point they can ask about also. What you will do for the risk reduction in the future pregnancy or in the current pregnancy. So you can incorporate these in your history taking, that I will ask them to do smoking cessation, because if they stop smoking at 15 weeks, the risk is back to the normal, just like if she has never had done smoking. Okay. Vitamin D, regular 10 microgram per day, and folic acid, balanced diet, energy, protein supplementation, aspirin from 12 to 36 plus 6. Previously I told 34 weeks, but no, it is up to 36 plus 6 weeks. Okay. There is no role of low molecular weight heparin. Now, examination part, already you know you will be asking about the BMI and the symphysiofundal height from 24 weeks. Then identify the reference chart to plot the symphysiofundal height, individual biometry, and estimated fetal weight. That I also told you. If the symphysiofundal height is there with you, you plot the chart. If the estimated fetal weight, you can use either of them. Estimated fetal weight, use the headlock formula. If you are using headlock formula now, again you are doing the growth scan, you will be using headlock again. Changing the formula will change the results. Okay. This one I was telling, for SGA fetus, every 2 weeks biometry along with every 2 weeks Doppler. For FGR, 2 weeks biometry but weekly Doppler. Okay. So umbilical artery Doppler is the primary surveillance tool. If they ask why, because its use in the high risk pregnancy has shown to reduce the mortality and morbidity. Okay. And also reduce antenatal admissions and induction of labor. This is also very important. If you see an SG or FGR fetus before 23 weeks of gestation, it could be due to some structure abnormalities. Which structure abnormalities? Not due to, which structure abnormalities? And if the uterine artery Doppler is normal, you should be thinking about some chromosomal abnormality. For that, you will be doing microarray to detect the micro deletions and micro insertion. And prenatal exome sequences should only be considered in cases with multicystic abnormality or isolated long or short bones. This is the advance. Then the genome sequences is advanced as compared to the microarray. So they say if there is like multi-system abnormality, then you should do prenatal exome sequences. It will tell you about different abnormalities, okay, the syndromes. Now SGA, I already explained. This is SGA, third and 10th centile, because below the third centile, it is not SGA, it is FGR. So if it is between third and 10th centile without any features present, so you will do birth at 39 weeks, 39 plus 6 weeks. But if other risk factors are present, you can consider earlier birth. For fetus with an estimated fetal weight or abdominal circumference less than 10 centile, where FGR has been excluded, birth or the initiation of IUL should be considered at 39 weeks. Okay. And birth should occur by 39 plus 6. Okay. So if there are no other risk factor, but if the SGA fetus is present along with some other risk factor like maternal condition, then you can start planning for the birth prior to 39 weeks. Is this point clear? For which patient up to 39 plus 6? For which patient prior to 39 weeks? Clear? This we are talking about SGA. Okay. But they can ask about this thing as well, that the patient is an SGA and after 39 weeks she's still not willing for the induction of labor. Then you can say that we can respect the wishes of the patient and can offer her the expectant management, and then there should be an individualized management plan. IUL is not a contraindication for SGA fetus. IUL between 37 to 38 plus 6 weeks for FGR. Okay, for FGR fetus. This one I already explained to you in the flow chart. So, and the one thing that is important, you should be You should know that you have to give steroids to your patient between 24 to 34 plus 6 weeks, and neuroprotection as well. And if they ask, the neuroprotection is offered between 24 to 29 plus 6 weeks and consider up to 33 plus 6 weeks. And if they ask what is the preferred method for IUL, then the mechanical method. This is for the future pregnancy. Future preventive strategies like smoking, aspirin treatment, and the notes record should be complete for the woman. And we can send the placenta for the histopathology. This is the normal ductus venosus Doppler, okay? And this is the A wave. So this A wave, if absent or reverse, it signifies a lot of things. Along with IUGR, we already know about the Down syndrome. Down syndrome also, if absent A wave, then the risk of Down syndrome is more. So they can give you this graph, the detail and the pathophysiology. You should not go into detail because it is very difficult and very extensive. But you just know about this thing, that this is the normal ductus venosus chart. This is the A wave. This is the reduced A wave. This is the progressive decreased A wave. And this is the reverse A wave. Okay. Already you know about the normal umbilical artery Doppler. This is the reduced end diastolic flow here. This is the umbilical artery. This one is the, you put the cursor on the red one. Okay. This is the absent end diastolic flow. This is the reverse end diastolic flow. This one we already discussed. So that's all about the FGR. Any question?
मैम पेशेंट को एडमिट किस टाइम पर करना है और आउट पेशेंट कैसे मैनेज करना है?
Okay. For which patient you want to ask specifically? SGA.
FGR.
FGR. Okay. All these monitoring is an outpatient monitoring. Whenever you are planning for the induction of labor, this is the usual protocol everywhere. Okay. Okay. Cesarean is,
एब्सेंट पे एडमिट नहीं करेंगे उसको?
what time you want to admit?
एब्सेंट रिवर्स फ्लो पे पेशेंट को एडमिट नहीं रखेंगे?
Why you want to admit the patient? क्योंकि अगर आप एक बार अल्ट्रासाउंड कर लें तो you will not do the, it is not a CTG that you will be doing continuously. Okay. So there is no recommendation for the admission of the patient, at least in the guideline. And usually what is the practice in the good hospitals, or you can say anywhere else in the world, that they only admit the patient a day before the induction of labor. Otherwise, they keep on monitoring the patient. Sometimes some specialists have this trend of following, that they admit the patient once the absent or reverse is detected, and now they want to plan the pregnancy. So how you can save yourself in this scenario, that if I am just planning the monitoring of the patient, I will do as an outpatient basis. If you just want to do the monitoring, why you want to admit the patient? But if you are planning the delivery in a day or two, or you want to admit the patient for neuroprotection, magnesium sulfate, because the steroid you can also give as an outpatient. Okay. So if you want to do some intervention, like want to induce the patient, want to do the seizure for the patient, or want to give the magnesium sulfate, then you will admit the patient. Okay.
Okay.
Okay, so Dr. Sunila was asking when we can go for the cesarean section, because we read that for SGH and IOL, right? And the mechanical is preferred. Whenever the computerized CTG is abnormality is there, like when you are planning for the cesarean there and then, okay, and just you want to go for cesarean or delivery, then what are those conditions? Because we already read, if the short-term variation is abnormal, if the computerized CTG is abnormal, if the ductus venosus is abnormal, whenever the umbilical artery Doppler shows absent or reverse end diastolic flow velocities, cesarean birth is recommended. Okay, and this should occur. ये नहीं है कि आपने डिसाइड किया This is also the answer to the other question, that the cesarean birth, when you have decided, you will go for cesarean after the administration of steroids and magnesium sulfate. So for both these things, you will admit your patient. Okay? Whenever you are planning. And if you are just planning to monitor the patient, then you monitor as an outpatient basis and admit when you want to go for IOL. Okay? Any other question?
मैम एक क्लास और रख लें स्ट्रक्चर डिस्कशन करने के लिए.
Okay. For the FGR?
Yes, ma'am.